PQA Innovation Theaters are opportunities for PQA member organizations to showcase their innovations, technology services, and research in a unique forum. This is your opportunity as an audience to learn more and ask about innovative solutions in the marketplace. We are thrilled to continue the 2020 Innovation Theater series with AllazoHealth. Bill Grambley is the Chief Operating Officer of AllazoHealth and is passionate about helping people get the most from their medications. Bill joins us today to discuss how AllazoHealth's AI engine predicts patient behavior and their response to interventions, and then targets interventions to help them achieve your program goals. So Bill, welcome. Please tell us more.
Great, thanks, Lauren, and thanks to all who joined today. So as Lauren stated, I'm going to talk a little bit about how you can use artificial intelligence to improve your patient engagement programs. Now, patient engagement programs really are designed to help people on their journey towards better health. Those programs often start out from kind of a mass-targeted approach, if you see on the left-hand side of this slide. You know, those are things like, as an example, somebody starts a new prescription and you send that person and everybody else, whoever starts a new prescription like that, some information about that medication and or how to take it, etc. But in reality, those are so mass targeted that many people will not even engage in that kind of approach. If you think about more and more customization and personalization of those types of engagements, and if you think about the spectrum on the slide, we can move to something that's more persona driven. So as an example, you could use demographics to help to segment out parts of your population and do something more personalized. What we're really talking about, though, is going beyond that and aligning your patient engagement solution to your individual patient's needs. The way to think about how this can work with the artificial intelligence solution is by first aggregating data across that population. On the slide here are some examples of that data that we leverage. Things like prescription claims or other prescription data, medical claims, and importantly, things like historical engagement data and or consumer behavior data. What we do then is take information like that and put it into our artificial intelligence engine. That engine does a number of things looking for relationships. We have a number of calculated variables that we do. And then using the information that it's gathered, the patterns that it's found, and the internal machine learning that it's been doing, it then makes predictions. It predicts each patient's risk of a specific outcome. The majority of what I'll talk about is related to medication adherence. And so as you could see on this small graphic, each patient will get a risk profile, and that risk profile will be related to a specific medication or therapy. So the first step, again, is that we predict the patient's risk of being non-adherent. The second thing we do then is think about each patient and prioritize the outreach based on several factors. One factor is how likely that person is to be influenced by a specific type of intervention. And so as an example, if you think about people who never answer the phone, it makes no sense to try and continue to reach out to them by phone. Conversely, there are people who don't open up any mail that you might send, and so it doesn't make sense to continue sending things to the mail when that person has shown no change in behavior in the past. So we look at how the patient, the individual patient, is likely to change based on the intervention. Combining the prediction and that prioritization logic, we then deliver a targeted list. And that targeted list includes the patient, it includes the type of message, That could be something like a refill reminder. It could be something like encouraging them to move to a 90-day supply. It could be something custom that your organization has created. But it will use the message, and then it will combine that with an engagement channel. Very typically, engagement channels include things like a live call. It could be an IVR or an automated voice type outreach. It could also be in person, or it could be using things like text message or emails. So the combination of that prioritized list based on the predictions is created into this targeted file that goes to your organization or your vendors. And those engagements are then attempted and delivered. Now, when those engagements are delivered, again, it could be across a wide spectrum of interfaces to that patient. But that attempt information and or delivery information and potentially more rich contextual information about those engagements can be fed back into the artificial intelligence engine. Then the artificial intelligence engine will learn based on that set of attempts. And if you think about the process this goes through, essentially this will occur on a weekly basis. So we make predictions, we prioritize the patients, we target them for a set of interventions. Those interventions are attempted and delivered. The response from those is fed back in, as well as information that comes from updated prescription information, et cetera. That then leads to new predictions the following week. Now, this process is one that produces highly accurate predictions and prioritizations, but can also then be related to any capacity constraints that your organization has. And those become really important, and we'll talk about an example in a minute, where you're trying to make decisions about which engagement, which message, which channel for each patient makes the most sense. So let me give you a couple of examples of how this works and the impact it can have. A few years ago, we did some work with Blue Cross Blue Shield North Carolina. That was part of their Medicare Advantage plan, and they were looking to increase STAR measures. A fairly sizable plan, over 100,000 patients. And in this example, in this case study, the plan had basically one type of intervention that was being studied. So even though the engine can predict multiple different interventions, in this example, it was a single phone call from a nurse. And the variable that we were able to affect was who got that phone call and how frequently did they get an outreach from the nurse. And in this example, there were three groups. There was a true control group that got no interventions. There was a group that got traditional-based outreaches, things like rules that triggered when a nurse would reach out. And then a third group that used our Allazo engine. And as you can see on the right, we saw a 5.5 times greater impact on the likelihood of the patient being adherent when we were able to identify the patients that needed the most support and then increase or decrease the intensity of those outreaches, the frequency of those outreaches, based on that prediction. They also saw a 23% decrease in the overall cost, partly because we were able to identify patients who were likely to become non-adherent later and intervene with them while they still had good habits, preventing those habits from becoming negative later. I'll give you another example. This was a recent case study that we did, and in this instance, and it's a decision that our clients make on a regular basis, who should get additional interventions. And so in this example, there were two interventions that were used. One was a call center, a regular phone call from a call center, and the second was an intervention from a retail store. Could either be a phone call from the retail store or an in-person from that retail store. We made predictions across the population, and the prediction was focused on who is likely to get the most benefit from adding that intervention. So adding a second intervention, in this case, the retail intervention, to a person who's already had this call center intervention. So we made predictions across the population, and then we randomly split people into two groups. One group only got the call from the call center. A second group got the call from the call center and this incremental intervention. Based on the predictions we made, we looked at the refill rate. And the orange line here are only those who got the call from the call center. And you can see that in general, their refill, percent refill rate decreased as the likelihood of the value of that incremental intervention increased. And then the blue line, which showed when we did that extra intervention, what kind of impact did we see? And as you can see, as the likelihood or the prediction indicated they would get more benefit from the retail intervention, the additional intervention, we actually saw higher refill rates for those patients when they got that extra intervention. So again, if you think about the decisions that you make from a plan perspective, who needs to get an incremental intervention? You can use predictions like this to decide who you want to do that extra outreach for. When you look at the impact then across the board, on the right-hand side here, if we didn't use any AI prediction and essentially that incremental intervention was available to all, we still saw an increase, and that increase was a little over 31%. But when we allowed the AI to do a prediction and really target in that extra intervention, which as we all know is extra cost, we were able to increase the impact 2.3 times to over 71%. Again, that is the way that when you think about how AI can be used, you can leverage it to make predictions on your population, then use those predictions to decide which group of people get which interventions. And in a case like this, if you want to test out a new intervention or you want to optimize your program, you can do it by using these predictions to decide who should get each incremental intervention. So those are two examples. We'd be more than happy to talk to you about others, but the summary here is that our artificial intelligence engine predicts that patient behavior and the patient's individual response to interventions, and then targets those interventions to align to your program goals, whether they're impact related, budget related, or both. And by using those predictive analytics, we can help increase the program effectiveness and efficiency 2 to 5x, as indicated on some of these examples. Here's some contact information, and Lauren, I'll turn it back to you for questions.
Thank you, Bill. As usual, our PQA members and audience here is quite engaged. So we have a few questions for you in the time that we have left. So we'll start with what sources of data do you have access to, and how are you using them, and can use rather?
Great question. So the predominant source of data is from our client, and that will typically include prescription information, medical claim information, and possibly historical engagement information. However, we can augment that with additional third-party information. Often there are holes in the data that our clients have, and so we can add to that by getting additional data sources, whether that includes other prescription information, EMR-based information. We can also get information about consumer behaviors, and that's something that we can include in here, which can include things like driving behavior. So there's a lot of different sources that we can bring in. The most common, again, are medical and prescription claim information and engagement information.
Excellent. And so continuing on with our data-related questions, how much data is your AI engine using today?
Yeah, great. Well, and if you think about artificial intelligence, more data is always better. Today, our database contains information on over 11 million patients. We're getting pretty close to 12 million. Across them, again, when we think about the number of claims, we're getting close to 1 billion claims that we're using within our engine. And then again, if you think about from an engagement perspective, how many interventions, that's also in that nearly 100 million range. So a lot of data is going into the predictions that the engine is using. And just to be clear, clearly no client information is shared across clients, but the engine, the AI, is learning over all the data it has available. And so it's always making improvements to its own predictive models.
Well, that was a nice segue into kind of my next question of an audience member asks, where do you think this could be applied beyond adherence? So could it be used to predict or facilitate the care of patients who are at risk for poor outcomes, or those who might be having some social determinants of health barriers?
Yes, and so today the big use case that we have focused on is on medication adherence. That also includes initiation of therapy, kind of in the same bucket. And so that could be, for example, a statin use in a person with diabetes. There are other examples where maybe you need a controller medication for asthma. Those are all well within scope. The same core components of this technology, however, can be used on a much broader basis. When we think of our applicability, we can predict outcomes. So in this example, adherence versus non-adherence. So we can predict that at the patient level. And then where there is an engagement approach to how we can influence that, that is where the end result is ideal. So for example, it's not quite as effective to do a single outcome like, did they get a flu shot? Although we have done that and we can do that. But when you think of ongoing outcomes, are there tests on an annual basis? Is there a behavior pattern like follow-up care? Is there a pattern around the usage of certain medical equipment that you would want to follow? All of those things are well within the scope of the technology that we have.
Excellent. And so one of our final questions here is, how accurate are your predictions? What's your measure of accuracy, I suppose? And this will be our last question, Bill.
Great. So thanks. The accuracy is one of the things that certainly increases the more exposure you have to a patient population. To give you a sense, we look at star measures, which I know a lot of people are concerned about. Star measures early in the year, so in the Q1 timeframe, we're looking at about 85% predictive accuracy. So what that means is, as of around the end of Q1, about 85% of the time we're able to predict where that person will end at the end of the year. That increases in accuracy over time. Whereas when we get into kind of late Q3, early Q4, when obviously we've got more experience and the measure end date is closer, that actually can get into the high 90s. And so when you think about the impact of that for your population, it really allows you to narrow in the targeting so that you're focused on the patients who are both at risk and you can influence.
Well, Bill, thank you very much for joining us today and sharing more about AllazoHealth's AI engine.